Hi everyone, my name's Kirsty and I'll be conducting today's webinar on antimicrobial stewardship and wound care. The session is quite lengthy. It will probably take up majority of the hour, so we'll just get started. So like I said, my name's Kirsty. I'm one of the tissue viability nurse specialists here at Coloplast, and we'll be going into antimicrobial stewardship in wound care during today's session. So the objectives of today's session are to introduce you to the three-step approach by Coloplast, which is a step-by-step framework which will help you effectively assess, prepare and treat wounds. We'll learn a simplified approach to wound healing. We'll understand the impact that wound infection and biofilm has on wound care and patients in general. We'll gain an overview of the latest best practice, including things from the International Wound Infection Institute and the importance of practicing antimicrobial stewardship in wound care. And you'll leave today with the three-step approach, antimicrobial stewardship pathway, to help you support you in practice, and that'll help you effectively assess, prepare and treat wounds. So we know that the wound care landscape is changing. There is more focus than ever for care to be taking place closer to home. Julie and Guest did some work in about 2017, 2018 and found that over 3.8 million patients with a wound are managed annually by the NHS. And that equates to a cost of around 2.7 billion for wounds that do heal, and wounds that don't heal, that's about 5.6 billion. It is estimated that 59% of chronic wounds heal if there's no evidence of an infection, compared to only 45% if there's a definite or suspected infection. The prevalence of biofilm in chronic wounds may be and is greater than 80%. And in some other research, 46% of healthcare professionals believe that infection is challenging when treating wounds. And if you factor that into the workload in nursing and wound care increasing and our workforce decreasing, wound infection is massive and creating a massive challenge in wounds. Wound infection is clinically relevant. Infection is a common wound complication and can be difficult to sometimes identify. We'll go into it in more detail further on in the webinar, but all open wounds are contaminated with microorganisms. So as soon as you get a cut, get a wound, there is some form of microorganisms that will be present within that wound because of what's naturally on our skin, and obviously whatever's caused the wound in the first place. Wound infection then occurs when those microorganisms that are already placed move deeper into the wound tissue and they start to spread and proliferate, which can cause local or systemic immune response. The host's immune system and the species of their microorganisms is what influence the development of the wound infection. Once a wound is infected, it does delay wound healing. It has an impact on the patient's quality of life. If you think about when you've got a throat infection or a chest infection, you feel really rubbish and really down and horrible. Well, the same applies obviously for a wound infection as well, especially when it's starting to kick over into being spreading or systemic. Your treatment costs rise, and that's down to obviously different products being chosen and also your time as well as clinicians. The wound care management practices also become more resource demanding. That'll be whether or it's the treatment plan that's being followed or the other care that's associated with it. So with a holistic approach, proper assessment and early intervention, many of these problems can be avoided and clinical outcomes can be improved. And that's what we're going to touch on today with the use of positive antimicrobial stewardship in wound care. So antimicrobial resistance occurs when bacteria, viruses, fungi and parasites no longer respond to antimicrobial medicine, and it's a natural process that happens over time, but it is accelerated due to misuse and overuse of common antibiotics. So that means getting prescribed them and using them when you don't really need them. Poor infection control practices, inappropriate hand washing, and obviously the lack of new antimicrobials being developed. I think nothing new has actually come up being developed since about the 80s. Due to this, drug resistance, antibiotics and other antimicrobial medicines are becoming ineffective, and infections are getting difficult and more impossible to treat, increasing the risk of disease spread, severe illness, disability, and death. And because of this, antimicrobial resistance is one of the top 10 global public health and development threats listed on the UK's risk register. And because of this, it is estimated that it is directly responsible for 1.27 million global deaths in 2019. So obviously that's pre-pandemic as well, if you think about that. So what that number is now, you're probably looking at it being doubled. As AMR continues to increase, more people will suffer from prolonged infections and therefore increase hospital stays. And if we don't act now, by 2050, 10 million people will die every year due to antimicrobial resistance unless a global response to the problem is done. So how does that relate to wound care? So as a result of antimicrobial resistance, topical antimicrobials are increasingly being used in wound care. So we're using topical antimicrobials rather than going straight to antibiotics. And the approach to combat this is known as antimicrobial stewardship, or you may see it abbreviated to AMS. AMS is important in wound care as multidisciplinary working is common because of the complexities and variations that come with it. It is critical that our practices minimise the possibility of microorganisms developing this resistance, and we can do this through healthcare professional education as well as patient education, letting patients know the importance of why they don't need an antibiotic straight away, why we can go to antimicrobials first or certain dressing choices first. Teaching also patients, if they're doing supported self-management, about wound hygiene, hand hygiene, all them things. We need to change traditional practices and processes, and we need to challenge them. An accurate assessment will help that as well. Preparation and treatment options with a physical mode of action, which we'll cover and come across in the webinar, and we'll delve more into that. And having increased awareness of antimicrobial resistance and antimicrobial stewardship will also help. So here at Coloplast, we've got the three-step approach by Coloplast, and that is put in place to simplify wound healing. So you've got step one, which is assess, which will use a holistic and wound assessment to define your treatment objectives. Step two is prepare, which wound preparation is key to removing barriers to healing and then creating the optimum environment. And step three is treat, where you'd use a simplified portfolio of dressings to manage the wound at any depth and stage of healing. And how we'll progress through this webinar is we will go through it, how to combat antimicrobial stewardship and wound infection through following assess, prepare and treat. So we'll start off with assess. So the aims of your wound assessment is obviously you want to identify the cause of your skin breakdown and identify any associated risk factors of why the skin's broken down in the first place, but why it would obviously prevent the wound from going on to healing. You want to correct and treat any underlying cause, such as venous insufficiency, and obviously if there's moisture lesions or pressure damage, you want to be relieving that and treating that underlying cause. You also want to be identifying the appropriate management options, whether or not that's to manage exudate, infection, pain. You want to be doing that so you get your patient to comply and concord with treatment. You want to control any wound-related symptoms so that it doesn't get any worse. It would also then prevent any further skin or wound breakdown or deterioration. You also want to identify your patient's expectations. Some patients out there, like one patient of mine in particular, he'd had his wound since 2002. So he never saw his wound ever healing. His expectation was just wanting to not be redressing his wound twice a day. And it's important to identify those expectations so that you get them on board, they do comply with their treatment, and then you can readjust their expectations as you go along. And you also want to be providing psychosocial support and promoting patient independence, because living with a wound can get people down. It can make them isolate. So it's important that those things are covered as well. And there's more a drive as well at the moment to promote supported self-management, which will help with that patient independence. So there are certain characteristics which can predispose wounds to infection. And in your acute wounds, these are your contaminated or dirty wounds. Any surgical procedure, even though they're done in the environment that they are done in, it still doesn't take away the full risk of developing an infection. If they have an acute wound that's been caused by trauma and there's a delay in treatment, whether that's a wait in A&E or them waiting to go and get it seen or do anything with it at home. If they've got a pre-existing infection as well, so if they've already got an infection elsewhere in their body, it can tip the wound because of the body's already trying to fight it off, so that host response. If there's any spillage from your gastrointestinal tract, inappropriate hair removal as well. And in your chronic wounds, the degree of chronicity can increase the chance of infection. So that's the longer that they've had the wound, because there's more chance of obviously a biofilm forming and more bugs getting in there, more microorganisms getting in there. The size and or depth of the wound, so the bigger and deeper the wound, the more likely there is for an infection. And if it's anatomically near a potential contamination site, so if you think of your pineal sinuses and things like that, they're obviously closer to a contamination area. So they're more likely to get infected. And then there's certain things which can predispose both acute wounds and chronic wounds to infection, and these are necrotic and sloughy tissue, or if there's a foreign body there. If the patient has, or the wound has poor tissue perfusion, a hematoma, if exudate and edema and inappropriately managed, wounds involving underlying structure or a bony prominence as well. So anyone can be at risk of developing a wound infection. The development of a wound infection is multifactorial and it occurs when cumulative risk factors overwhelm the host defense system. Factors that deliberate the patient, impair the immune system's response, or reduce tissue perfusion increase that risk of infection. So when we're talking about the patient as an individual, these things can include poorly controlled diabetes, any prior surgery that they might have had, certain medications, conditions associated with hypoxia or poor tissue perfusion, immune system disorders, inappropriate antibiotic prophylaxis, which then falls into antimicrobial stewardship and antimicrobial resistance, protein, energy malnutrition, and alcohol, smoking, and drug abuse. Then there's also so this is what you would do in these situations. So you want your optimal host response. So you want to be managing any comorbidities as well as the wounds. You want to be effectively managing any diabetes, so making sure their blood sugar levels are in the right range. You want to make sure that they're optimized nutritionally and obviously hydration as well. So making sure they're getting the right amounts of protein, a balanced diet, and drinking enough water. You also want to be treating and any other sites of infection that they might have. Manage any pain and fever that can be through obviously certain dressings or paracetamol, ibuprofen. Educating the patient and the care as well, like I've already touched upon, providing that psychosocial support, ensuring you've got your patient's cooperation, and minimise or eliminate any other risk factors. As well as the individual's risk factors to a wound infection, you've also got the environmental factors as well, and these can include hospitalisation. So obviously there's loads of different people that are obviously poorly with different things in hospital, different microorganisms and bugs that are in there. So obviously if you're already going in and being unwell and you have a wound, it just increases your chance from there. If there's an unhygienic environment, if the patient or even the healthcare professional has poor hygiene and poor aseptic technique, inadequate pressure offloading, repeated trauma such as inappropriate dressing removal, inadequate management of moisture, exudate and edema. So to combat these, you'd ensure that your wound care is done in a clean environment. You'd do the appropriate aseptic technique based on your risk assessment of the patient, the wound and the environment. It might not always be suitable for you to do a full aseptic procedure. Sometimes, especially if you're working in the district, in the community, working in patients' homes and things like that, you have to kind of do the best with what you've given. You want to again be providing your patient and the care with education of why you're doing it and why you're doing this way. Review any policies and procedures you have in your local area and store any equipment appropriately. Our wound assessment and our patient assessment is also going to help reduce the risk of wound infection through that early identification and treatment. Can help reduce or eliminate infection and that's also clinically as well as economically beneficial to facilitate that wound healing. It'll also reduce the impact on the patient and also the healthcare system. So your patient then won't have the detrimental quality of life because they have a wound, and also it won't have the impact on the healthcare system by putting pressures on more time to do the wound care, but also the more costly dressing choices as well. A holistic and collaborative approach is vital to the delivery of best practice. Collaborating with the patient in care decisions can help reduce the physical and psychosocial impacts of wound infection. So getting them to fully understand what you're doing, why you're doing it, and the outcomes that will come off the back of it. Also, through identifying the risk factors through the assessment and addressing them through education is essential. A comprehensive wound infection prevention and treatment plan should be developed from a holistic assessment and should optimise and address optimising the individual's host response, reducing local microbial burden, and promoting a positive environment for wound healing. One of the ways that you can effectively perform a wound assessment is through the triangle of wound assessment, which extends the concept of wound preparation and other assessment tools beyond the wound edge, so it incorporates that peri-wound skin. So it focuses on the wound bed, the wound edge, and the peri-wound skin, and you'd assess all these different areas separately and then come up with a combined treatment plan for what is needed for the wound. When it comes to assessing your wounds for infection, the wound infection continuum, is the most commonly used, and most of you might have seen this in your practice. And what it does is it breaks down the stages of wound infection into these 5 different categories, which we'll break down, and they're contamination, colonization, local infection, spreading infection, and systemic infection. And as you can see from the blue triangle that's on your screen, contamination is just what happens with all our wounds. If we've got a paper cut now, our wound would be contaminated. And the triangle slightly narrower at that end because there's less microorganisms in that wound. And as you kind of go up the scale to systemic infection, obviously the triangle gets wider because there's more bugs, the host response is overwhelmed, and that's how it steps over into that systemic infection. So for contamination, the wound is contaminated when non-proliferating microorganisms are present. In a contaminated wound, your body can naturally destroy the microorganisms. There's no signs of infection, and it's a steady state of microorganisms. Your body can constantly fight them, and wound healing will progress as normal. In your colonization stage, the microorganisms start to undergo a limited proliferation, but there's no significant host response. The bacteria are starting to grow and multiply, but at a non-critical level. They're not damaging any tissue, and at this point there may not be any significant effect on wound healing. There is guidance now to suggest that from the colonization stage, this is where you need to be mindful of where biofilms are starting to form, and we'll cover what a biofilm is further on in the webinar. So you need to be mindful that from colonization, you really need to be stepping it up, looking out for your signs of infection and biofilm, and doing something about it before it tips over into the local infection, stage. So at local infection, the microorganisms have proliferated, they've moved deeper into the wound bed, and you're now seeing a host response. The response is localized to one location, system, or structure. So for obviously the purpose of wound care, it would be located in the wound. Then microorganisms now are starting to multiply, and your signs and symptoms may be subtle, or you could see your classic signs. So your subtle signs, hypergranulation, any bleeding, epithelial bridging or pocketing. Your wound could start to break down. You might start seeing delayed healing. So you might have seen your patient on Tuesday, and the wound looked like it was progressing normally, but then you see it again on Friday and it's broke down further. It might start to bleed a little bit. You might start to have a little bit of malodor, or the patient might be in a little bit of pain when you're changing the dressing. Then you've got your classic symptoms. So these are the ones that we all know and associate with infection. So you've got your erythema, you've got your redness, obviously your heat, your swelling, purulent discharge, delayed wound healing, and pain and malodor. After this, the next stage is your spreading infection. So they have now, the microorganisms have now proliferated and they've started to invade the surrounding tissues. You'll see all the signs on the previous slide that I've just shown going on in the wound bed. And you also might start to see early systemic infection indicators. The patient now might be turning around and saying to you that they feel unwell because of the wound. And then the final stage in the continuum is your systemic infection. So this is it's affecting your whole body as a whole, that microorganisms have spread throughout the body via the vascular or lymphatic systems. And this is where you're seeing your sepsis, your organ dysfunction, and that systemic inflammatory response. So like I said, throughout the continuum, you've got that line over the top where it says that a biofilm can be formed. And we're now looking at 4 biofilms in your colonization stage. So a biofilm is a structured community of microorganisms with genetic diversity that create chronic infection. They're not visible to the eye, but signs of infection indicate that they're there and that they're present. Research suggests that 80% of non-healing wounds do create a biofilm, and they are categorized by their significant tolerance to antibiotics and antimicrobials while remain protected from the host's defense, so that our body can't do anything against them. As I said, they're not visible to the naked eye, but your sign of infection would indicate that they're there. So your delayed wound healing, increased exudate or slough, increased inflammatory response, any redness around the wound, any malodor, and a high bacterial load. Biofilms do keep that wound in your inflammatory state. So you've got your stages of wound healing, and biofilms do keep them in that second stage, in that inflammatory stage. So you'll have a non-healing wound, which is an ideal environment for biofilm formation. Biofilms then cause a chronic inflammatory response. That chronic inflammatory response leads to tissue damage and a delayed wound healing, and round the cycle goes. So we really do need to get our wound care practices in there to disrupt what's going on and stop that biofilm forming so that wound can heal. There are critical complications when it comes to wound infections. Those, sorry, gone a bit too click happy. So they can have additional complications. Your wound infection is a common complication, but you really need to be careful that the systemic infections don't click over into things like necrotizing fasciitis or osteomyelitis, and like I said, sepsis. If you are concerned about sepsis, it is a life-threatening complication. It is because there's presence of microorganisms in the blood. The overall signs and symptoms of sepsis include excessive pain, confusion, disorientation, shortness of breath, shivering, fever, or a very cold temperature. It can go one way or the other, so just be careful on that one. A high heart rate, clamminess, and localized signs of infection. If you do suspect sepsis, it is 999 and a rapid investigation where in it they will take a blood culture and they will be given IV antibiotics. When it comes to taking a microbiological analysis, you need to be kind of following the following steps and doing it appropriately. So if you take a wound swab, if your acute wounds have classic signs of infection, if your chronic wounds are showing signs of spreading or systemic infection, if you have infected wounds that fail to respond to antimicrobial treatment or are getting worse despite the antimicrobial treatment, you do it in line with your local protocols, your local policies, and also if you need a wound swab for certain surgical procedures like donor grafts and things like that. But they should not be performed routinely. You should always have a reason. The last time I checked, a wound swab cost about £18 to conduct, so they are quite an expensive thing to do if you don't need to do them. So there are the 5 rights of antimicrobial stewardship, which are 5 pointers that will keep us on the right track to support us in doing positive antimicrobial stewardship. And they are the right diagnosis and care plan, the right antimicrobial and delivery system, the right time to initiate antimicrobial treatment, the right antimicrobial dose, the right duration of antimicrobial treatment. And to make that simple, and here at Coloplast, what that means for us is appropriate education, and that's on the principles of antimicrobial resistance and antimicrobial stewardship, as well as appropriate product choice, where you would choose the right dressings for what you're seeing in your assessment, and then also the appropriate duration. And this covers things like your 2-week challenge, but also when it's the right time to step up and step down from your antimicrobials or your other dressing choices. So that's wound assessment. So what we'll do now is we'll go into wound preparation, and we've split it into 2 sections for you. So we're going to cover wound preparation and wound treatment if your wound has got an infection or biofilm, and then wound preparation and wound treatment for your wounds that are at risk. So for your wound infection, preparation for your wounds with wound infection and biofilm, we know that slough and non-viable tissue and biofilms can all delay wound healing process because they obviously increase the risk of infection, as I've already said. They obviously inhibit the development of your healthy tissue because it can't grow and migrate over, but they also limit your wound assessment as well. So if you could have a wound that you take off the dress and it looks like it's 90% covered in slough, but actually if you'd performed wound preparation, some of that slough may have been lifted and it might now only be 20%. So you've got a different wound assessment going on, which would lead to a different treatment choice as well. And as I've already said, 80% of non-healing wounds contain a biofilm. It has been clinically proven that cleansing and debridement does speed up wound healing. By preparing the wound and cleansing prior to applying a dressing, it has positive results and it can speed up treatment. So the data that is on the screen at the moment is from the Wilcox study, and what this found was that in diabetic foot ulcers, in wounds that were prepared at least once a week, they went on to heal in 21 days. Whereas in wounds that were prepared once every 2 weeks, they had a medium healing time of 76 days. So it is a big difference if you do factor in wound preparation. The Wounds UK do have best practice recommendations on wound preparation and cleansing debridement using all prep pad, and they do have this table to kind of highlight the different types of cleansing and debridement. So you've got washing and cleansing in the green at the top, which can be done by anybody, doesn't need any specific competencies or training, and it's important just that everybody does that. Then the ones in the turquoise, you've got your autolytic debridement, your mechanical debridement, biological debridement, and enzymatic debridement. And these are the ones that don't require an extended competencies or training, but it does require to have that little bit more knowledge over the format of the debridement that you're doing, but also the product choice that you're using. And then you've got your sharp and your surgical debridement, which does require extended competencies, and obviously surgical debridement is done in theatre. One method of debridement which can be done by anybody, including healthcare professionals and the patient, is your mechanical debridement, and that can be done with all prep pad. And this is the international best practice for the management of biofilms infection does say that step 1 in that management of biofilm and infection is wound preparation, and that's where you would cleanse and debride the wound to reduce the number of microorganisms by disturbing and removing some of them as well. Wounds should be prepared at every dressing change where possible. The aim of wound preparation is to accelerate the healing and to facilitate that effective management of treatment plans. It is an approach that should be taken at every wound care intervention, and it can help your assessment, your clinical judgment, treatment goals, and also pain levels as well, because pain's associated with infection. So if you're preparing your wounds, you're removing them barriers in your slough and you're disturbing the biofilm, you're reducing the number of microorganisms that are in there and therefore reducing the infection. So you'll take it back down that scale. It should be done regularly, and like I demonstrated with the Wilcox study, it does have an effect on healing rates, and it can be done if you pick the right mode of debridement and wound preparation. It can be done at every dressing change. There are times when you should be cautious with wound preparation, however. So if you've got a patient that has a wound on the lower limb and is known to be diabetic, they may not be suitable and might need some further advice and support. If a patient has a known arterial flow concern or poor localized tissue perfusion, and if their healing is impaired because of medications or underlying medical conditions such as your immunosuppressed. Also be cautious in your wounds that might be fungating or you think that might be malignant as well. I'd also seek a special advice there. In relation to the 5 rights, or the 3 that we've got here at Coloplast, wound preparation follows that appropriate product choice because it allows for that better delivery of your treatment and your dressing that you choose to dress your wound with, because it's creating the right environment as well, that if you did choose to use an antimicrobial, that antimicrobial is delivering the right dose to the wound bed. So what we'll do now is wound infection and biofilm, and we'll treat in wound infection and biofilm. So you've got your different treatment objectives that you will have highlighted and highlighted in your assessment and then reconfirmed after your wound preparation. Your treatment objectives should aim to support that optimal healing environment for the wound, and you want to be looking for the management and prevention of things like exudate or exudate pooling, protection of the peri-wound skin, maceration and excoriation, the depth and cavity of the wound, and also infection and biofilm like we've been covering today. International best practice for the management of infection and biofilms says that step 2 is to apply a barrier dressing that would prevent maceration by the manage exudate and prevent recontamination as well. You then also want to be doing your infection management for infection and biofilms. So you want a dressing and an antimicrobial that's going to suppress biofilm formation, reduce any existing biofilms that have remained in the wound bed and any microorganisms, and all that's done with the active ingredient in the dressing. So some of them active ingredients could be your silvers, your PHMBs, but also you can also get things like metronidazole gel and silver sulfazine. So your antiseptics are disruptive and have a biocidal effect on bacteria. They have multiple sites of antimicrobial action with low risk of bacterial resistance. They're non-selective, so that means that they can cause skin and tissue damage if they're not delivered in the wound bed in a sustained manner. And they're recommended for local wound infection, but also wounds that are at high risk of infection as well. So then your antibiotics should only be used in specific circumstances by experienced clinicians. They're not recommended for general management of wound infection, even in low doses, and it should be used with when the degree of infection cannot be controlled by another local intervention. So you really want to be focusing for your antimicrobial stewardship. You really want to be focusing on your silver antimicrobial sort of dressings. So when it comes to topical antimicrobials, these come in various different forms. You can get them in liquids, paste, creams, ointment sprays, impregnated dressings, you name it, and it'll come in that form. How they're used and how frequently you should change the dressings depends and varies on the product. Some can be used every day for only a short period of time. Others need reapplication several times a day, and some can be left in contact with the wound for several days. The ones that you're most likely to see are things like your honey, your PHMB, iodine, and your silver. For today, we are going to focus on silver. So silver is a topical agent, and it's been used for thousands of years in wound care to prevent and treat infections. In recent years, a wide range of wound dressings containing silver have been developed that are easy to apply and provide that sustained release. By providing that sustained release, you have got an active agent in the dressing that is in constant contact with the wound that is stopping that biofilm formation. So you are doing positive AMS, you're stopping the biofilm from forming and allowing the body to fight any microorganisms that are there and also help heal the wound. So you're taking it back down that wound infection continuum. Silver targets multiple sites in the bacteria. You've got silver ions which bind to the bacterial cell wall, blocking the transport of substances inside and outside the cell. Silver ions are transported into the bacterial cell where they block the respiratory system, destroying energy production, so it stops it from basically breathing. They also interact with the DNA and inhibit the bacterial cells division, stopping it replicated so it can't replicate and cause more. And that's how it works, and that's how it has a knock-on effect to be able to stop biofilm formation, because it's stopping the bugs from replicating and killing them off, basically. So if we think back to our continuum, when would we implement a antimicrobial? So if we've got contamination, here we know that the body's been able to fight what's currently going on in the wound, so therefore a topical antimicrobial dressing is not indicated because it's not causing clinical problems. If we click over and go on to in between colonization and local infection, this is where your antimicrobial dressings are indicated, because you're going to have a suspected biofilm or a confirmed biofilm. And then here in between spreading infection and systemic infection, this is where you're going to be using your antibiotics as well as your antimicrobial dressing. You'd have both. You wouldn't just use one or the other. You still need to, even though the wound has flicked over into a spreading infection, you wouldn't stop your antimicrobial. You would still use your antimicrobial as well as your antibiotics. One of the things in the 5 rights, or in our simplified 3, is the right duration of when to use your antimicrobials in the first place, and when to start them. But also there is something called the 2-week challenge, which means that you should use your antimicrobials for 2 weeks to ensure that they've been effective. It should be individual based on the assessment and regular wound assessments. And after this period, the wound, the patient and the management approach could be re-evaluated according to the diagram that is on the screen. So after 2 weeks of implementing an antimicrobial, if you see an improvement, but there is continuing signs of infection, you'd continue with your silver dressing and have a review in 2 weeks. Obviously, you'd review the wound in between that, but you would continue with the silver for 2 weeks to ensure it's working effectively. If after 2 weeks you've got improvement and no signs of infection, you can stop that silver treatment and step down to your non-medicated wound dressings, which I'll cover in the next section. And then if you've got no improvement after 2 weeks, the silver dressings should be discontinued, and consideration should be given to a different antimicrobial agent, or this is where you need to maybe start looking to see if the wound's flicking over into the systemic infection, and you might need some antibiotics. So as I said earlier on, we have split the presentation into preparing and treating wounds with an infection, and then preparing and treating wounds that are at risk of infection. So with your wounds that are at risk of infection, these are your wounds that are progressing. So you are seeing healing, but for whatever it could be, individual patient risk factors or wound risk factors, or both, the wound is at risk of developing infection. So whereas with your prepare and you treat for your wounds at risk of infection as a biofilm, there is a suspected or confirmed biofilm or infection there, or your wound is static. For this section, it is your wounds at risk, but it is progressing. So it's really important that you still are preparing the wounds that are at risk of infection, even if there's no signs of infection, because that appropriate wound preparation and management can reduce the likelihood of wound infections developing. So you've got your wound in your colonization or your contamination phase, if by doing appropriate wound preparation, you're going to stop it flicking over and stepping over into your local wound infection. Through wound preparation, you are removing any barriers which could delay healing and therefore reducing the risk of infection. So you're removing the slough, you're removing the devitalized tissue, and you're removing the microorganisms that could therefore increase that risk. Wound preparation can help prevent the formation of biofilm for the same reason, and it reduces the bacterial burden, which helps prevent the microorganisms from multiplying, proliferating and moving deeper to the wound bed, and therefore not causing a host response. And like I said, it remains in the colonization of the contamination phase of the continuum. So when it comes to treating wounds that are at risk of infection, you still want to be using a non-medicated wound dressing. So there is literature that prompts the use of these dressings to support positive AMS. And these dressings are to minimize the risk of developing an infection, as these dressings absorb and retain exudate and bacteria. So these barrier dressings have a physical, non-medicated mode of action that supports wound bioburden management, because the dressings such as biotin, silicone retain exudate and bacteria up to 99.8%, therefore reducing the risk of infection and that damage to the peri-wound skin, the wound bed. So you are again stopping the wound from flicking over into a more further up onto the continuum. There may be times due to your assessment where prophylactic use of antimicrobials may be required. This is only if, following your full holistic and wound assessment, your wound and or patient has been assessed as being high risk of developing a wound infection, that you might need to use cautious use of a topical antimicrobial. So these might be in immunocompressed patients. I've had to use it personally and use prophylactic use of silver and biotin silicon AG in a patient who was an IVD use or an intravenous drug user who was very erratic in their appointments and cooperation in their wound care. So prophylactic use was used then because of the high risk of the patient. If you do assess your patient as being high risk and the need for antimicrobials prophylactically, always speak and discuss this with your local wound care specialist and or in line with your local policy. But sometimes it's better to be safe than sorry and using the prophylactic use than obviously getting further down the line and needing antibiotics, but always discuss it with the specialist first. So hopefully that's made life easier when it comes to antimicrobial stewardship in wound care. It's really important that as clinicians we do reduce the problem that is antimicrobial resistance. The government have developed a 5-year action plan to help combat the crisis, which should reduce the need for unintentional exposure to antimicrobials. They want to optimise the use of antimicrobials as well. Investing in innovation, supply and access. They want to be a good global partner. So they are learning from counterparts all over the world to see what they're doing in regards to antimicrobial resistance. For us as clinicians, we can improve on our infection prevention and management. We can increase our awareness and education on AMR, which is what you guys have done today, and we can challenge inappropriate antimicrobial usage, try and use antimicrobials appropriately, and operate an antimicrobial stewardship way of working. So that should have covered antimicrobial stewardship using the 3-step approach by Coloplast, where we would effectively assess the wound to see if obviously it's the holistic assessment of the wound and the patient and any infection that might be there to see if we do need to kind of go down a positive AMS and prevent anything from happening, or if we need to actually treat a wound infection. We'd then prepare the wounds to ensure we're removing any barriers to healing, creating the right environment, removing that bioburden from the wound with all prep pad, and then you'd treat depending on if you were treating an infection or just trying to prevent by using a non-medicated wound dressing that retains bacteria and exudate. We do have our antimicrobial stewardship pathway that follows the assess, prepare, treat message. So your assessment would be the same across the board. The pathway is split into your wounds that have no risk factors present, local infection, spreading infection, and then you would follow the arrows down. Wound preparation is the same regardless of obviously if the wound is infected or not. You either want to be getting rid of any microorganisms that are there causing the infection or that could cause the infection, and then your treatment would then depend on if you're going to use an antimicrobial or not, depending on if a wound infection is present or a biofilm is present or not. On the back of the pathway then gives you a simplified product selection guide. So you've got your non-antimicrobial dressings, which help trap and retain the bacteria and the exudate, such as your biotin silicon. And then you've got your antimicrobial dressings, which obviously have that active agent, such as silver in your biotin silicon AG, that would help fight off any microorganisms there. And regardless, wound preparation would be the same with all prep pad and provide that antimicrobial wound mechanical debridement to reduce the antimicrobial activity in the wound. So that's everything from me. Has anyone got any questions?
Brilliant, thank you, Kirsty. Oh, where's my camera? Here we go. There we are. Lots of comments in the chat relating to wound preparation and the different things that people use, talking about aseptic non-touch technique and how people can increase that in the community, which I have said is very difficult given the environment that they're in. It's not always particularly safe to wash your hands in some people's homes.
No,
so you have it's generally seen as a clean procedure in the community. Of course, you can do non-touch technique when you're opening your dressings and ensuring you're putting your gloves, etc. on. Lots of people saying it was a really good session, very informative. Yeah, I don't think there's any specific questions. There was a couple of questions around Inadine, so I've pointed people towards that company's website to have a look at that a little bit more. Yeah, brilliant.
Oh, good. Brilliant. Well, thank you, everybody. I hope it has been beneficial. And it obviously you can all go away and implement positive antimicrobial stewardship in wound care following this session.
So we will be sending out certificates, and you will also get a copy of the recording. And if you go to the Coloplast Professional website, you will be able to sign up for further webinars that we're doing throughout the rest of the year. But thank you all for joining.
Thank you.